To understand induction of labour, we need to first get to grips with what labour actually is. In most pregnancies, labour starts naturally between 37 and 42 weeks, only 4% of babies being born on their due date. At first, you may experience irregular, painful contractions. These contractions often stop and start. This is called early labour or the latent phase. This is when the neck of the womb or cervix starts to become softer and shorter and may take several days, particularly in first-time mums. Although contractions may be uncomfortable, it is not considered active labour. Active labour is when you are experiencing regular painful contractions and your cervix is progressively changing. Contractions are painful enough to take your breath away or make you stop what you're doing and stay still. You can see that the cervix has become much shorter and has thinned. When you have an examination, the top of the baby's head can be felt. As labour continues, the cervix dilates to 10 centimetres and baby's head comes down in your pelvis. This is when your cervix can no longer be felt around the baby's head. This is called the second stage of labour and signals the time that you can start pushing. We prefer for labour to start naturally. However, we offer induction of labour when we feel that the benefits of waiting for natural labour are outweighed by the potential risks to you and your baby. The recommendation to induce labour is not made lightly and should be fully discussed with you so that you can make an informed decision. There are a number of reasons why women may be induced. Induction of labour is recommended to reduce risks to either yourself, baby, or both. Common reasons include: you are more than a week past your due date, your waters went over 24 hours ago and labour has not started, your baby is smaller than expected or has stopped growing appropriately, your baby is estimated to be especially large, you are not feeling baby move as much, you will be 40 years old or more when baby is due, you have a medical condition such as diabetes or kidney problems, or you have developed complications during your pregnancy such as preeclampsia or obstetric cholestasis. You and your doctor or midwife will make a plan for your induction of labour, and the week of induction will be agreed at your antenatal appointment. If we are particularly busy, we may need to rearrange your induction day or time. How we induce labour depends on why you are being induced, how ready your cervix is for labour, and whether you have had a caesarean section before. The plan for your induction will be discussed with you before it commences, and you can discuss any concerns you have. Most women start with a hormonal method of induction. ProPes is a vaginal pessary that looks like a very small tampon and contains the hormone prostaglandin. This helps to ripen the cervix and might bring on tightenings. The main aim of this step is to prepare your cervix for labour by making it soften and encouraging it to start opening. This allows us to then break your waters. Some women will start labour with just a ProPes, especially if they have laboured before, but most don't. ProPes can be inserted by either your midwife or doctor during your initial vaginal examination. It has to sit quite high up in the vagina, just below the cervix, and stays there for up to 24 hours. After 24 hours, you will be offered a vaginal examination to see whether it is possible to break your waters or not. If you go into active labour or your waters break whilst having a ProPes, then that's great. However, this only happens in a small number of women, and don't be disheartened. Hormonal methods of induction are used in women whose cervix is unfavourable. Unfavourable means we cannot comfortably break your waters or insert a cook balloon. The hormonal methods are ProPes pessaries and Prostin gels. These contain prostaglandins which help to ripen the cervix and might bring on tightenings. The main aim is for your cervix to soften and start to open so that your waters can be broken. ProPes is a vaginal pessary which sits inside the vagina for 24 hours. Prostin is a gel that dissolves in the vagina. It is used when your waters have broken spontaneously but your cervix is still unfavourable. ProPes will be inserted into your vagina by either a midwife or a doctor. It has to sit quite high up in the vagina, just below the cervix. After 24 hours, you'll be offered a vaginal examination. If your cervix is still unfavourable, you will be recommended to have a Prostin gel. If you go into active labour or your waters break whilst having a Propes or Prostin, then that is great. However, this only happens in a small number of women. Don't be disheartened. Hormonal methods of induction are generally avoided in women who have had previous caesareans or complex fibroid surgery. This is because it increases the chance of the scar on the womb coming apart. Hormonal methods are also avoided in women who have had 3 babies or more, or in women with small babies who have stopped growing. This is because there is a greater risk of hyperstimulation or excessive contractions causing fetal distress. A Cook balloon aims to create gentle pressure on the cervix, making it thin out and open. It stays in the cervix for around 12 hours. It might be used if you have already had a Propes pessary and it is still not possible to easily break your waters, or you are unable to have a Propes pessary. Common reasons for not being able to have a Propes pessary include having had a previous caesarean or complex fibroid surgery, having had 4 babies or more, having a baby with significant concerns about fetal well-being such as growth restriction. A Cook balloon is inserted by doing a vaginal examination either with our fingers or with a speculum, similar to when you have a cervical smear. The Cook balloon catheter is threaded through the cervix and a balloon is inflated just above the cervix under the baby's head and membranes. The second, lower balloon is then inflated just below the cervix in the vagina. The cervix is gently pressed from both sides, encouraging it to thin and open. In order to have a Cook balloon placed correctly, the cervix has to be at least 0.5 centimetre dilated so that the tip of the deflated balloon can fit through. If your cervix is completely closed, then a Cook balloon will not be possible. If your baby's head is very high and not fixed in the pelvis, then a balloon may not be appropriate as it could push baby's head further away. This does not happen if your baby's head is fixed in the pelvis. It is often best to insert the Cook balloon with your legs placed in the lithotomy position so that your cervix is easier to reach. This may be uncomfortable. However, most women don't find it any more uncomfortable than having a pessary inserted. As Cook balloons rely on mechanical pressure to open the cervix, there is less risk of hyperstimulating or contracting too much. Very few women go into labour with just the Cook balloon. The main aim is to thin and open the cervix so that your waters can be broken. ARM, or artificial rupture of membranes, means breaking your waters with a small hook. This is ideally done when your baby's head is low in your pelvis and the cervix is soft and dilated. The midwife or doctor will examine you and break your waters using a small plastic hook. Once your waters are broken, your baby's head should be able to press on the cervix and bring on contractions. Walking around or bouncing on the birthing ball for a couple of hours may help contractions come on. ARM can only happen on delivery suite. Sometimes you may need to wait for a delivery room to become available to ensure you receive one-to-one care from a midwife. This usually happens in a few hours, but if the unit is busy, this may take a day or so. Most women having an induction will start off having hormonal methods, a balloon, or both, until it is possible to break their waters. Some women are assessed and it may be possible to break their waters from the start, bypassing other methods of induction. These women tend to have had vaginal deliveries in the past or be later on in pregnancy. In women who have had complex fibroid surgery or a previous caesarean, balloon methods or ARM are the preferred routes of induction. If you do not start contracting following having your waters broken, or you are contracting but there is minimal change in your cervix, then you may need the hormone drip. This is more likely if you have not had babies born vaginally before or are earlier in pregnancy. This is a drip of oxytocin, the hormone that brings on contractions. The oxytocin is given via a cannula or drip, which is put into a vein in your hand. The oxytocin is then started off at a low level and is increased gradually until you're getting regular, strong contractions every 2 to 3 minutes. An outpatient induction is where you can go home with a Propes pessary in. You will need to come to hospital to have a review, vaginal examination and have the Propes inserted, as well as a normal CTG trace before and after the Propes insertion. Outpatient induction is only suitable for some women where the risks are thought to be particularly low. For example, those being induced for being overdue or because of a suspected big baby. There must be no concerns about baby being too small or having reduced movements. Women must live less than 45 minutes away from the hospital and have ready access to transport to easily get to and from hospital. They must have a responsible adult with them at home and have access to a phone and have a good understanding of English. If you would prefer to have an outpatient induction, or indeed prefer not to have an outpatient induction, please discuss this with a doctor or midwife booking your induction. First of all, you have a vaginal examination, and usually a propest pessary is inserted into the vagina for 24 hours. After 24 hours, the pessary is removed and you are re-examined. If it is not possible to easily break your waters at this time, you will be offered either a cook balloon, a further propest pessary, or a caesarean section. If a cook balloon is placed, this is usually left for around 12 hours. Following the balloon, it is very unusual not to be able to break your waters. When a midwife and delivery room are available, you will be able to go to delivery suite and have your waters broken. We recommend at least 30 minutes of CTG trace before and after having your waters broken to ensure your baby's well-being. We then usually suggest walking around for 1 to 2 hours and using the birthing ball to try and bring on contractions. If contractions do not start, or if they do, but there has been no change in your cervix, you will be offered the hormone drip. It can take a variable time after starting the hormone drip for the contractions to become effective. We normally suggest waiting 3 to 4 hours after regular, strong contractions before doing another vaginal examination. The length of time taken for active labour to be established is very variable, but tends to be longer if you haven't had babies in the past or are less than 39 weeks. We would advise you to bring books, an iPad, Kindle, games, or anything to keep you occupied. Once you've been admitted to hospital for induction, you normally stay until after your baby is born. Induction of labour can be a difficult process to get your head around. Please bear in mind that every maternity unit does it slightly differently. All medical interventions have an element of risk, and we need to be certain that the risks associated with induction are outweighed by the potential benefits. The main risk of hormonal methods is hyperstimulation, or making you contract too much. This can eventually affect baby's heart rate pattern and in some cases cause babies to get tired or distressed. This is more likely in women who have had multiple vaginal deliveries in the past. If hyperstimulation occurs, then the hormone drip can be stopped or the hormone pessary removed. If needed, an injection to temporarily stop contractions can be given. Women who have had an induction of labour tend to find labour more painful than those who go into labour naturally. This is more common in women who need the hormone drip and is probably because the hormone drip makes your contractions as good as they possibly can be. As a result, more women being induced have an epidural in labour. This is an injection into the back which provides very effective pain relief in labour. Women who have epidurals are a bit more likely to need help to deliver baby when they start pushing. This may mean either a ventouse, which is a suction cup on baby's head, or forceps, which are like metal salad spoons that cut baby's head to speed up delivery. Induction of labour does not increase your chance of having a caesarean, and in fact there is growing evidence that it reduces your chance of having a caesarean. This is probably because when we induce before the natural onset of labour, the placenta is younger and therefore better able to cope with the stress of labour, and the baby is smaller and more likely to fit through the pelvis. If you are being induced, you are no longer able to go to the midwife-led unit. You will only be able to have your baby in delivery suite and will need to have continuous monitoring of baby's heartbeat during labour. This means having the CTG trace, which involves having the stretchy bands on your tummy. If you need the oxytocin or hormone drip, this means that your movements are a bit more restricted, as the drip is given through a pump that is plugged into the wall. You can stand or sit on the birthing ball. Induction of labour can be a long and unpredictable process. There can be a lot of waiting around and there are often delays. This reflects us having to balance women who walk in labour with women who are booked to come in for inductions and elective caesareans. Priority will always go to women who need induction most. This may mean that they are unwell or we have concerns about their baby. Induction of labour often requires more vaginal examinations than if you went into labour naturally. If you find vaginal examinations really uncomfortable, then you can have gas and air to help you. If you start contracting on the ward during your induction, then you can have simple pain relief such as paracetamol and dihydrocodeine. You are also more than welcome to use your TENS machine, a birthing ball, or use the bath. As we have already mentioned, your chance of having an epidural is increased when you are induced. Having an epidural is a personal choice. If you are induced, this does not mean that you have to have an epidural unless this has been specifically discussed with you. Very rarely we are unable to get someone into labour. This either means we can't break their waters, or they have been on the drip for a prolonged period of time without contracting or making progress. When we can't break your waters, then sometimes we offer to give you a break and then restart the induction process again. You also have the option of having a caesarean. If a woman has had her waters broken, but has been on the hormone drip for a prolonged period of time without making any progress, then we would recommend having a caesarean. This situation almost only ever happens in women who have not had babies in the past, and is more common in women who are less than 39 weeks.